Okay. Well, hello everybody. My name is Raymond, and my research supervisor is Dr. David Klonsky from the Personality, Emotion, and Behavior Lab. Today I'm presenting a scoping review about interventions for reducing suicidal thoughts and behaviors and self-injurious behaviors in autism spectrum disorder. So what is autism spectrum disorder? Autism is a neurodevelopmental disorder characterized by deficits in social communication and restricted repetitive patterns of behavior. Self-injurious behavior is any action that is directed towards oneself that injures. And suicidal thoughts and behaviors are thoughts or deliberate actions towards the self with the desire to die. I will use the terms self-injury and suicidality interchangeably with SIB and STB respectively for this presentation. Self-injury and suicidality are highly prevalent in autism populations. For autistic populations, empirical evidence for self-injury interventions are quite well established. However, no reviews have been conducted on interventions that reduce suicidality, despite immense risk and prevalence. Therefore, the present study conducts a scoping review to map the existing evidence for interventions that reduce self-injury and suicidality in ASD populations. It also seeks to identify methodological gaps where future research efforts can be applied. To be eligible, studies needed to have an intervention for self-injury or suicidality and report some measure of effectiveness. Participants needed to be diagnosed with ASD. PubMed and PsycInfo were the databases searched, and Distiller SR was used for screening and data extraction, which was all done by a single reviewer. A descriptive summary of intervention studies was provided, and interventions were placed into common categories for analysis. Overall, 2009 studies were identified through the literature search. After removing for duplicates and screening, 101 studies met the full inclusion criteria and were included in the final analysis. This study has 5 major findings, but for today's presentation, we will only focus on 3. Firstly, there are very many self-injury studies, but very few suicidality studies examining interventions in the ASD population. Of the 101 studies, 91 were interventions for self-injury, while only 10 were interventions for suicidality. It's worth noting that 9 of these 10 suicidality studies are case studies, making it hard to generalize results to the larger population. Secondly, there are no studies using the leading psychological therapies for suicidality in ASD populations. Among suicidality studies, 6 intervention types were found, where pharmacological and family or parent-related interventions were the most common. But again, since there are only 10 studies present, these proportions may not really matter that much. More interestingly, if we look closer at the types of interventions used, dialectical behavioral, cognitive behavioral, and interpersonal therapy, which are the leading psychological therapies for suicidal ideation, aren't used in any of the 10 studies. So it's a little surprising to not see them here. Lastly, all suicidality studies use assessments that aren't yet validated for ASD populations. In all the suicidality studies, the most common assessments and reporting methods were clinician report and patient report. This is troubling because self-report might not be reliable or valid across different clinicians or patients. And if we look closer at all the reporting methods and assessments, we find that none of them are actually validated in ASD populations. So to recap, this study has 3 main findings. Firstly, there are very many self-injury studies, but not a lot of suicidality studies examining interventions in ASD populations. Secondly, there are no studies using the leading psychological therapies for reducing suicidality. And lastly, all suicidality studies use assessments that aren't yet validated for autism spectrum disorder populations. This study does have a few limitations. Only 2 databases were searched. Reviews were only conducted by a single reviewer, which has been shown to miss 13% of reviews. No assessment of study quality or publication bias was done. And it's important to note that these don't represent the frequency or proportion of interventions used in clinical practice, only in the research literature. Based off the key findings, future research should look to validate current suicidality assessments or create new valid assessments. And lastly, conduct randomized controlled trials with leading psychological therapies. Thank you very much for listening to my presentation, and I'd like to welcome any questions or comments at this time.
Thank you so much.
I'm sorry, is it okay if I ask a question?
Yes, go for it.
I was going to ask if, like, in the research on suicidality and autism, if there was any difference in the representation of females and males, but given that you have so few people even doing that research, or 10 studies, I'm sure that's hard to say. So I guess I'm just wondering, in general, were any of the 10 looking at females with autism?
In terms of, I can speak probably more confidently in the larger data set overall. Overall, autism is more, males are overrepresented across all autistic populations, and I don't recall examining the gender of the participants in the specific data set you're referring to, but then overall they were, they say that 75% of autistic diagnoses are male. So, but that's something I didn't quite look at.
Thank you.
Raymond, I'm just curious about what your sense is, and this could just be like your hypothesis about why there is such a lack of research on suicidality relative to self-injury in this population, if it is the case that both are prevalent.
Well, it's really interesting because the prevalence rate, I only briefly noted this in the slides, but really the prevalence rates for suicidality, and that includes ideation and completion or attempted suicides, really only have been established in the past 5 and maybe 10 years. Our best population-based study was out of Sweden, and that was done in 2019. That showed that there's a 5 to 7 times greater risk in autistic populations, but that was only done last year. So I think where the research literature is at is that we know that people on the spectrum are at greater risk, much greater risk. We know that there might be some risk factors and protective factors that we're aware of, but because assessments haven't been validated, we can't measure interventions properly. I think that's just where the research literature is at. As to why, I'm not quite sure, but the diagnosis of autism in the DSM-5 and 4 only came out in the early 2000s, so that might be part of the reason why.
Yeah, that makes sense. Like the knowledge just hasn't caught up yet for there to be enough time for the related research to catch up. Thanks.
Mm-hmm.